Hi, good morning, team. My name is Jermaine. I'll be giving report on patient that I took care of last night. The patient is a 52-year-old male with past medical history of refractory T-ALL leukemia lymphoma. His status post cycle 1B augmented hype CVAD, which was complicated by NSTEMI. Patient underwent a hard CAT, which was determined the hard CAT showed that he had a EF was 25 to 29%. This was back in February of 2019. However, the patient's EF has since improved to now 59. The patient initially resumed his chemo, but unfortunately, he had progression of his disease. He was started on a single agent nelarubin, but had progression of neuropathy. He's now status post 2 cycles of cyclophosphamide etoposide. Patient was discharged home September 10 with plans for CAR T trial that was scheduled for September 23rd. However, he unfortunately had progressive weakness and paresthesia to the bilateral lower extremities, abdomen and back pain, urine retention, and he returned to the hospital on the 13th. Neuro was consulted, images was negative for tumor infiltration into the CSF, and they initiated empiric IVIG for acute inflammatory demyelinating polyneuropathy. Yesterday, while this patient was receiving blood transfusion, he became tachycardic with heart rate in the 160. He was febrile, Tmax of 103, rigors, tachypneic, respirations in the 30s. He was flushed and was also hypotensive with systolic blood pressures initially in the 70s. The patient was given Demerol IV with Benadryl by his attending and also ordered for normosaline 1 liter. The patient was refractory to fluid boluses, blood pressure continued to drop, and so the nurse called the rapid response and we responded. In the past, the patient, so when we got there, we gave him another fluid bolus. He was still refractory to it, systolic state in the 70s, and so we initiated epi and no epi, and we initiated transfer to the ICU. Anyway, his past medical history: anxiety, cancer, degenerative disc disease from L5 to S1 level, hypocholesteremia, hypertension, and hypertriglyceride. Surgeries: he's had a hard CAT in March of 2019. He also had a removal of a superficial lipoma back in 2012. Family history of colon cancer in his maternal grandmother and maternal aunt. He has coronary artery disease in his mother. Mother also had hyperlipidemia, hypertension, ovarian cancer, and pancreatic cancer. His paternal grandfather had a stroke, and his dad only had a hypertension. Social history: he's a former smoker. He said he smoked half a pack a day for 5 years. Pack year 2.5, and he smoked a cigarette, and he has quit for over 30 years. He said he's never used smokeless tobacco. Alcohol use: he used to drink 12 standard drinks a week. That should be about 12 cans of beer per week, and he frequently binge drink, I guess to say. Never used drug. On review system, he was positive for chills and fever, HENT negative, cardiovascular wife negative for chest pain, positive for dyspnea on exertion, leg swelling, no, negative for leg swelling, near syncope, palpitation. Respiratory wise, negative for cough, endocrine negative, hematological and lymphatic negative, skin negative, musculoskeletal negative, GI negative for diarrhea, nausea, or vomiting, GU. He had a Foley because he came in with urinary retention. Neuro, progressive bilateral lower extremity weakness, 3 out of 5. No psych issue, negative for psych. On physical examination, upon arrival, his blood pressure was 78/44. Pulse was in the 150s to 160s. Temperature was 103. Respiratory rate 26. Saturating at 88%, and then complain of a pain score 7/10. Patient was cooperative. He was sickly looking, tachypnic, and verbalizes being short of breath when he tries to move. HEENT, normocephalic, atraumatic. The pupils were equal, round, and reactive to light. Extraocular movement intact. No neck is supple. Trachea midline. Cardiovascular wise, tachycardic. Heart rates up in the 160s. Exam reveals no gallop, no murmurs were heard. Pulmonary wise, breath sounds were normal. There was slight use of accessory muscles because he was, breathing fast. No rales. His abdomen exhibits distension. Bowel sounds were decreased. GU, he had a Foley in place which was draining, clear yellow urine. Neurological wise, patient was awake, alert, and oriented ×3. Extremity pulses were strong and palpable. Bilateral lower extremities edema was noted, and also the bilateral lower extremity weakness, 3 out of 5, and paresthesia. Skin is warm, dry, and intact. He is not diaphoretic. There's no pallor. Face flushed, and his extremities were a little bit cold to touch. Psych, no psych issues. Patient was intact. On a differential diagnosis, the first one was CS with Rygers, which was multifactorial because this patient is immunocompromised. So also concerns for sepsis. Is it early septic shock? Possible source could be bacteremia versus pneumonia, or versus post blood transfusion reaction. So we initiated a sepsis protocol. Patient had already received a liter of fluid bolus. We added another liter of fluid bolus. We also he was already on some antibiotic coverage, but we would call ID to get more coverage. We added vancomycin because patient was already started on meropenem. We discussed with the primary team on the fluid status, and given that the patient has a history of CHF, patient clinically appears dry, so we gave additional 1 liter for a total of 2 liters now. Sent some labs. Patient's lactic acid level came back elevated, and so possible Rygers versus. So at this point we're thinking, lactic, could it be possible due to volume depletion or sepsis? So we're just going to trend the lactic, and then we gave him some bronchodilators too. And second differential was neutropenic fever, pancytopenic. WBCs was 0.14, HNH was 7.7, and his platelets were 58,000. Patient is on Valtrex, diflucan, and augmentin. He was started on meropenem in the afternoon, and we added vancomycin for empiric coverage after talking with ID. Hematologist is on board. The blood transfusion, of course, was stopped and sent to the lab. Patient had 1 unit yesterday, so we're suspecting transfusion reaction, possibly non-hemolytic febrile transfusion reaction, with no restriction for future product. No, the blood was, we stopped the blood, sent to the lab, and this is what came back from the lab. The suspected transfusion reaction, possible non-hemolytic febrile transfusion reaction, and there was no restriction for future product pathology note. Third was third differential to just throw in there, bilateral lower extremity weakness, which patient is already receiving IVIG for AIDP. Per neuro, we just continue the IVIG, and then of course the urinary retention, patient has a Foley in. So that's my patient. Thank you all. Bye.